Good morning and good afternoon, everyone, and thank you for joining today's live webinar. My name is Rudy Inaba. I'm the Director of Clinical Relations and Corporate Development for Cenegenics, and today's topic is cardiovascular health, looking at heart disease and stroke prevention. So I always like to start off with some statistics or quotes, and this really hit home for many people, is that every 37 seconds in the United States, there is a heart disease-related death experienced from our population. This here's a map to show the brevity of the impact of heart disease and mortality across the country. So actually, when we go over this presentation, if it's roughly 45 minutes or so, that's looking at around 70 to 75 different deaths that have occurred during this conversation. So heart disease is the leading cause of death in the United States. It's responsible for almost 650,000 deaths annually. And that's around 12% of the population, so 30.3 million US adults. Behind that is also stroke. Stroke is the fifth leading cause of death, and it's responsible for almost 150,000 deaths annually, and that impacts 7.8 million US adults, or roughly a little bit over 3% of the population. Now, talking about heart disease and stroke, one thing that is very common and that many people are aware of to track is our cholesterol levels. And across the board, the U.S. has significant issues with our population and cholesterol levels. Roughly 95 million U.S. adults have total cholesterol levels higher than 200 milligrams per deciliter, which is the common borderline range for most physicians. And of that group, 25 million U.S. adults actually have total cholesterol levels that are higher than 240 grams per deciliter. So we have much more tiers that go up, and still very large numbers of individuals that express elevated cholesterol. The thing that is difficult for patients is that many people don't know they have elevated cholesterol because there really are no symptoms directly for cholesterol levels. You need to get your blood work done. You need to work with your physician. And that obviously raises significant risk factors as we get older for heart disease, stroke, and also metabolic syndrome. So with cholesterol, many people are familiar with it. Many people have heard the term. We've even heard the terms bad cholesterol, good cholesterol. So for today's call, we're going to be looking into some advanced testing methods, but I also want to review some of the more traditional methods that are done for clinicians and physicians when checking our patients' heart disease risk factors. The first is our LDL cholesterol, or our low density lipoprotein, and that is what's considered the bad cholesterol. And it's bad because it actually carries cholesterol from the liver and out and around into the bloodstream. And this is an issue because it can potentially lead to plaque buildup, as you can see in the image, those yellowish cells. That is our LDL, and as they get pulled there, they can accumulate and stick to the insides of the walls of our blood vessels. Our high-density lipoprotein, our HDL, is what we consider our good cholesterol, and that's shown in green in the picture. And that actually carries plaque away from the arteries, back to the liver, and then for excretion or removal by the body. We can't really talk about cholesterol without also talking about triglycerides, which are kind of like the cousin of cholesterol. And triglycerides are also a lipid that circulate in our bloodstream. However, there's some really positive things that they do. They provide energy to our tissues for normal function. They also provide insulation for our core temperature regulation, and they can even protect our organs from injury. As we go through our slides in this presentation, I have reference ranges of what Cenegenics physicians aim to shoot for our references. For one being for low density lipoprotein, numbers lower than 100 milligrams per deciliter are preferred to really manage our risk factors. Having a good cholesterol or a good HDL above 50 milligrams per deciliter, and also keeping triglycerides below 100 milligrams per deciliter. So with heart disease is a broad term, and it covers a large spectrum of potential issues in individuals. So those conditions of the heart can be coronary artery disease that can be developed over a lifetime, heart failure, myocardial infarction, arrhythmias, and even birth defects, so congenital heart defects that our individuals could have that increase their risk factors as we get older. So the American Heart Association, they recently shared some of the top findings of 2019 as it relates to heart disease. The first being pulmonary hypertension, and how having low BMP9 proteins in individuals are seen when someone has pulmonary hypertension. So it's a new value that we could potentially start to look at from a clinical side as far as managing our risk factors with pulmonary hypertension. And another one is actually a genotype of BOLA3 gene that holds a relationship with patients that have pulmonary hypertension or that are at risk for it. More advancement in the studies that we look at from circulation and JAMA include older women and exercise. And Circulation published an article that demonstrated that 60 minutes per day decreased heart disease by 26% in women in their 70s, I believe. Additionally, JAMA published an article showing that more active individuals, so when people who are gardening or walking or staying active, actually have a 42% lower risk of myocardial infarction or coronary death. So this is obviously something that we've known for quite some time. However, we see that it's still important, even as women get older, even into the late 70s, that this little bit of exercise and activity can yield really significant benefits and cut down on our risk factors related to heart disease. Another interesting one, if you've been following our webinars over time, I believe in September, we did our webinar on Alzheimer's disease and the risk factors associated. And we recently found that blood pressure levels, specifically a systolic blood pressure being lower than 120 millimeters of mercury, lowered risk of cognitive impairment and dementia risks pretty significantly, and that was presented by JAMA. So we know that there's a correlation, there's a relationship between Alzheimer's risk factors, inflammatory markers like heart disease, diabetes, and metabolic syndrome, and now more and more data is just coming to really support those concepts. There was also a new prescription drug that was released this year in 2019 called Vascepa, and Vascepa is a fish oil that is 99% pure EPA. So there's no DHA. Most fish oils are commonly EPA and DHA, and both are beneficial. However, Vascepa is it's isolated just EPA for elevated triglycerides. And typically, if someone has a triglyceride level over 500, that's when they would be prescribed a triglyceride drug. And this fish oil is now available, and it's done in either 500 milligrams or 1 gram capsules, and those are taken either 1 to 2 times per day based on the individual. As a side note that I found interesting, Cenegenics, we have our own marine fish oils, and our marine fish oil single servings, we yield around 480 milligrams of EPA and almost 200 milligrams of DHA. So we have a very strong available product, not only to our patients, but also available on our retail store that is very similar in strength to even prescription grade fish oils. They also found new gene studies. So there were 22 regions of the human genome that were found to correspond with venous thromboembolism and peripheral artery disease. And that was a study that was published by Nature and Genetics, and that included patients of up to 650,000 people. So it's very interesting. So any of our patients who have done the genome testing, or if you've done genome testing with your physicians and you start to see more and more information coming out on a monthly basis to give you updates of what's going on, you'll very likely see some of this information soon. So with stroke, so many people talk about heart disease and they include stroke in that, but let's take a look directly at stroke and what it is. So stroke is a disease that affects the arteries that are leading to and within the brain. So this is more brain related. And when part of the brain can no longer get oxygenated blood, so we deliver oxygen via our bloodstream to our body for our cells and our tissues, when the brain can no longer get oxygenated blood, it leads to brain cell death. And there are actually 3 types of stroke. It's not just one thing. The first is ischemic stroke, second is the hemorrhagic stroke, and also the TIA or transient ischemic stroke. So an ischemic stroke occurs when a blood vessel that carries oxygen and nutrients to the brain is blocked by a clot. And that's very common. That's what most people think of when they think of stroke, is that there was a clot and it became blocked and it blocked those vessels from providing that oxygenated blood. Another one is related to hemorrhage. So this occurs when a blood vessel that carries that oxygenated blood and nutrients to the brain actually ruptures. So there can be an actual rupture of the vessel, and that can lead to someone bleeding outside of that vessel wall and losing the oxygenated blood. And a transient ischemic stroke, or a transient ischemic attack is commonly called, or a TIA, is nicknamed a mini stroke. And this is when a temporary clot occurs. So all the symptoms of stroke that we're going to get into in the next slide can be related to a TIA. It can be short term. It's scary because you don't know the severity of it when it's happening. It could be a full-blown stroke, but it could also be just the transient ischemic stroke. We do know that if you are having frequent TIAs, that it could significantly increase your risk factors for a more aggressive ischemic stroke. The American Stroke Prevention, or the American Stroke Association, goes to say that 80% of all strokes are preventable. So that really shows us that There are so many different lifestyle factors that we can incorporate to really improve our risk factors for not only stroke, but also for heart disease. And that is shown through measuring our biomarkers, living high quality lifestyles that include specific nutrition, exercise, and nutraceutical goals, and potentially hormone management if it's indicated by our physicians. So more on stroke with the Stroke Association is that they are having a large push of how to spot a stroke, because in many times, especially with women, I mean, you may have heard that how many women have actually had heart attacks without even really knowing it. The symptoms maybe weren't perceived as so aggressive, but there are women that have potentially had more than one heart attack in their life that hasn't gone treated afterwards. So we want to focus, or the Stroke Association wants to focus on how to spot a stroke, and that's through the FAST acronym. And FAST meaning face drooping, arm weakness, speech difficulty, and then it's time to call 911. So if you are experiencing this, or if you have a family member that's experiencing some of these symptoms, these are not normal things that abruptly happen. So if you do see this, make sure to call 911. There are sudden symptoms with stroke that come on very abruptly, and this is similar to the TIA or the mini stroke, and that's sudden numbness or even confusion, changes with depth perception, trouble seeing, trouble walking, and even severe headache. So let's look at some of the common risk factors. These are likely done in your health history or any kind of physician appointment you've done or any blood work you've done in the past. These are some of the common factors that are looked at from clinicians to get a good idea for our heart disease and stroke risk factors. So the first being elevated blood pressure. So blood pressure is measured very easily as a vital sign. We measure two different values, being a systolic and diastolic value. Systolic, you want to have, I'm sorry, these are, the numbers are wrong. So it's actually less than 120 millimeters of mercury. And diastolic, you actually want less than 80 millimeters of mercury. So anything under 120/80 is going to really help improve our risk factors over time for developing heart disease. Typically, if you see someone get up into the 140/90 range, it's when they're going to start to consider medications for elevated blood pressure or hypertension. Cholesterol levels. So we have an elevated cholesterol level. If you have elevations, you're going to be over 200, as I mentioned before. So cholesterol levels can be looked at as LDL, HDL, and also non-HDL cholesterol. So when we look at those combined, then we actually see what our total levels are. Typically, in the past, when someone was over 200, a primary care physician would be somewhat quick to prescribe cholesterol medication. However, trends have changed. So now more 220 to 240 consistently, for a period of time is kind of the range now for medication. We really want to see what's going on if there is a strong elevation in HDL or if there's low LDL. Because there's a little bit more variances going on when we look at cholesterol. The American Heart Association even says how 50% of heart attacks that occur come from people with normal cholesterol levels or recorded normal cholesterol levels. So there's just looking at this total cholesterol, it's a good thing to look at, but it's not really the true picture to manage our risk. Elevations in blood sugar. So if there's a fasting glucose level that's greater than 86, if you've had if you didn't fast for the 12 hours, that might be giving you a false positive. But someone that's fasted for 12 hours and they're reading fasting glucose levels above 86 into the 90s, even above 100, that could be cause for concern for potential risk factors as we get older with heart disease and also type 2 diabetes. Same goes for poor insulin sensitivity. So if your fasting insulin level is greater than 5, it's typically correlated with elevated body fat levels, inactivity, and poor diets. That can also not only increase risk factors for type 2 diabetes, but also metabolic syndrome and heart disease. Smoking is a big one. We tell everyone that if you could do one thing to really start to improve your health immediately, quitting smoking would be the best thing you could do because it has the most bang for your buck. You're going to see the most improvements across the board in many places, from hormone production to heart disease management to fasting glucose. It's going to do a lot to remove that from your lifestyle. As I mentioned, excess body fat. So we don't want to focus solely on BMI or just height to weight ratio. For patients from large scale population studies, BMI makes sense where you need to look at a lot of different data. But when we're able to work hands-on with our patients and our physicians can work so closely with them, we look directly at body fat percentages. And excess body fat for men is going to be over 20% total body fat. And for women, it's going to be over 25% total body fat. We can get into the ins and outs of how that body fat is stored and what's more risky. with our patients. More of the fat that's stored around the gut or in the trunk, also known as visceral fat, is going to be highly inflammatory, and that's going to yield a much more significant risk for heart disease. Inactivity is another risk factor. If you think about it, our hearts, we supply oxygenated blood to all of our tissues, and exercise makes our heart rate increase because we need to pump oxygenated blood to those muscles faster. So if we are inactive or if we do not exercise, our heart is not trained to do that and to function aggressively. So inactivity for decades over time are significant risk factors for developing heart disease as we get older. In relation to that is a VO2 max score. So with VO2 max, we measure dynamic cardiac output. So meaning how well the heart, lungs, and muscles work together during peak levels of exercise. And we measure that by a score being the relative VO2. And individuals that pump less than 20 milliliters of oxygenated blood per kilogram per minute are actually at significant risk factors for heart disease and stroke as they get older. Another one we look at that are commonly done in clinical labs are cardio-CRP levels, which is a marker for inflammation. And excuse me, anything over a 1.0 consistently over time could be a potential cause for concern for chronic elevations of or chronically elevated risk for inflammation. Someone may have a elevation of a 9 or a 10 or a 15 or even a 50. Commonly, if that's seen in an acute response, it could be a patient being sick, or it could be from an injury. If I bench pressed and I hurt my shoulder and I got my blood drawn the next day, I would probably have a high level of cardio-CRP, typically because of the acute inflammatory response to start to heal the body from that injury. It would be more of a cause for concern if we do lab over lab, maybe every other month or every quarter, where we see a chronically elevated level in the 3 or the 4, 3.5, and it's not going away. That's going to be more concern for chronic inflammation. So we looked at a lot. So, I mean, many patients, both ours and also from if you're working with your primary care physician, you can look at a lot of different values to assess your risk factors right now. However, I do encourage everyone to discuss with your physicians, whether you're inside or outside of Cenegenics, to look at some additional risk factors that are available for our patients and physicians. So one of the biggest things we do for our diagnostic assessments with our patients when they come in for their elite health evaluations is our carotid intermedial thickness test. Additionally, when we take a look at the actual physical test of the ultrasound and measure it with some of the labs we're going to go over, we can significantly assess our risk factors much deeper than what we can do from common lab work. So we can see some of the terms here like the F2 isoprostane. We're going to be looking at myeloperoxidase and some other ones in here that are more additional advanced tests that we can look at for inflammation, our cholesterol levels, and also even genotyping. So we're going to first look at the inflammatory markers that are advanced that you can look at to assess your risk factors. And the first one is myeloperoxidase. And myeloperoxidase is actually a protein-based enzyme, so it helps with enzymatic function that can be easily oxidized. It actually contributes to tissue damage during inflammation. So if you're experiencing inflammation of the vessels or your intermedial is thick and you're inflamed, the elevations in myeloperoxidase can actually contribute to this tissue damage. And it is very well associated with atherosclerosis, which is the hardening of the arteries, and also the instability of plaque, the plaque being able to potentially break off and then create a blockage somewhere, creating stroke or heart attack. We also look at the plaque test. Plaque test is also known as LP-PLA2, and having that value be less than 200 is the ideal goal. This enzyme actually promotes inflammation inside the arteries. So while injuries are more inflammation on the outside in an acute response, this is a perfect example of chronic inflammation. So if you have chronically elevated levels of high sensitivity CRP, and then we see an elevated plaque test, we know that there's significant risk factors for developing unstable plaque in the arteries that could actually be more rupture prone for the individual. A little bit more information on the high sensitivity CRP, or the cardio CRP as I called it. We want that level below 1. And that is a protein that's produced by the liver, and it's increased due to inflammation. And as I mentioned, the inflammation can be from anything. It can be chronic inflammation or it can be acute inflammation. So it's good to get a full picture of everything. The 5 values here are all markers for inflammation. So if we see something that's a strong elevation in high sensitivity CRP, but we see other elevations and all these other markers, we know that the CRP being elevated is not from an injury, and it's also from chronic inflammation. We look at ratios of some values as well. So we look at microalbumin and creatinine ratio. We want to have that less than 30 milligrams per gram. And that is a marker for a loss in vascular integrity and endothelial dysfunction. So our vessels, our blood vessels, they need to be pliable to changes in blood pressure, changes in, with exercise. When we exercise, our heart rates increase, our changes in blood pressure are experienced. And we need our vessel walls to be able to have the integrity to do so. As we get hardening of the arteries and we develop atherosclerosis, those vessel walls don't become as pliable and they start to become dysfunctional. And this is going to be a good marker for us to see how far along the line we are. And elevated levels of this ratio are actually 3 times more likely to develop cardiovascular disease with the aging process. Another ratio is the F2 isoprostane and creatinine ratio. And these are inflammatory markers that are produced by free radical oxidation. So as that inflammation keeps building and building and building, and we keep oxidizing free radicals, those inflammatory markers are going to change. And that's why we want to monitor these to really assess our risk factors and see how far along the line we are for heart disease development. Another issue with the F2 isoprostane ratio is that it promotes platelet activation. That can lead to thrombosis or blood clots. So when you stack all these things on top of each other with a thicker intermedial wall, potential plaque built up, and then also platelet activation that can lead to clots, you're really kind of putting together the perfect storm for having a cardiovascular event. So there are also advanced lipid tests that we can do, and that is the ApoA1 test. We want to see levels above 120 milligrams per deciliter. And this is a primary protein that's associated with a good cholesterol, so with HDL. So if you have good HDL levels, we're hoping that your apolipoprotein A1 is also elevated, because elevated or increased levels are associated with reduced risk factors for cardiovascular disease. Apolipoprotein B, on the other hand, is the different story. We want to keep that level down under 100 milligrams per deciliter, and this is attached to the LDL cholesterol. If someone has a level that's above 120, they actually carry a 3-time risk for developing cardiovascular disease as they get older. And patients that have normal LDL, so we said a normal LDL or a good LDL was below 100, someone can have normal LDL and actually have high ApoB values, which are identifying then small dense particles. So that's another important reason why, how I mentioned the American Heart Association, they say how 50% of cardiovascular events are occurring in individuals with normal LDL levels. So if we're able to look at our individuals or our patients that have normal LDLs and also look at their ApoB values, then we can get a better idea of what those risk factors are over time. As with our previous ratios, we also look at an ApoB, ApoA ratio, as that's going to correlate with our risk for cardiovascular disease as we age. Additional lipids we can look at are SD-LDL, and we want this under 40 milligrams per deciliter, as this aids in risk management of lipoprotein disorders. LP-A, this is LDL with an inherited apoprotein attached. And elevated levels of this are actually associated with hardening of the arteries or atherosclerosis, and it presents a 3 to 5 times higher risk for heart attack in the individual that has a level higher than that 30 milligrams per deciliter. We also look at HDL2B. We want that above 25%. This HDL2B level is really, it parallels many risk factors with type 2 diabetes and insulin resistance. Low levels of this are actually associated with insulin resistance, and levels decrease with weight gain or fat gain, and they can increase with diet and high intensity exercise or high intensity interval training. So it's very much similar to HDL, where we can really change those values pretty significantly on the same way that we would focus on fat loss. Now moving on to some genotyping. So we can also look at genes that our individuals carry when we do our lab work to assess very comprehensive risk factor analysis. So ApoE, you may have heard, again, I referenced the Alzheimer's disease presentation we did not too long ago. ApoE is another genetic variant that we can look at to manage our risk factors, not only for Alzheimer's, but also for heart disease. So it is associated with lipoprotein metabolism. So there's 3 alleles that play a role in influencing our cardiovascular disease. And ApoE2 is really the most rare. And if someone has ApoE2, that may reduce our risk for Alzheimer's disease by 40%. If someone has ApoE3, which is the most common, roughly 60% of the population has ApoE3. That's the most common allele. And ApoE4 actually is one of the most significant ones for Alzheimer's disease risk. Each one of these, we get one allele from each parent. So if I'm ApoE2 and ApoE3, I may carry a low risk for Alzheimer's disease and also a low risk for cardiovascular disease. If I'm ApoE3 in both scenarios, I'm going to carry low risk, but not quite so much if I had an ApoE2. If I have one allele of ApoE4, so if my mother or my father gave me ApoE4, that could potentially increase my risk for Alzheimer's by around 30%. And if I have two alleles of ApoE4, depending on the literature you're looking at, that can increase your risk for developing Alzheimer's by 50 to upwards of 90%. So it's very significant to know this stuff. So ApoE4, as it's increasing your risk factors significantly for Alzheimer's, it also increased risk factors significantly for hardening of the arteries and stroke. And that's where the correlation comes, because that stickiness that we see in the firing with the plaque and the tau in Alzheimer's, it's happening in the brain. And that's also potentially doing similar things to our vascular system, increasing that risk factor for stroke, heart disease, cognitive impairment, and also dementia. KIF6 is another genotype, and this is comprised of proteins called kinesins, and they play a role in our intracellular transport of organelles, protein complexes, mRNAs, and individuals with polymorphism, or polymorphism is like a gene variant. Anyone's with this gene variant, they actually have a 55% greater chance of developing cardiovascular disease. And the last genotype we have is 9p21. And this is actually recognized as the strongest genetic marker for cardiovascular disease. And this polymorphism or genetic variant, it can actually cause early onset myocardial infarction or abdominal aortic aneurysm. So it's a significant risk factor for having a major cardiovascular event. And it also triggers molecular actions that contribute to the inflammatory signaling in our endothelial cells. So all of these genetic variants are good to know if you have a family history of heart disease, if you are coming off of living a fairly poor quality of life as far as it relates to nutrition, exercise, nutraceuticals, stress. It may seem overkill at times to try to know all of this information. However, gathering as much information as possible is really important to assess the severity of where we're at in our health and how aggressively we need to make an action plan and execute that plan. There are additional items like adiponectin. Adiponectin, if someone has low levels of those, are actually at a 3-time greater risk for developing metabolic syndrome. They are also at a 9 times more likely to develop type 2 diabetes, 2 times increased risk or the prevalence of coronary artery disease. And the fortunate thing is that increasing your omega-3 intake, like we talked about, that the new drug that was released, Vascepa, it's a marine fish oil. So taking marine fish oils, eating more omega-3s in your diet, you can actually increase your adiponectin levels by as low as 14, but even upwards of 60%. So it's very significant that we can change with diet or nutraceuticals. CoQ10 levels are another one. So low levels of CoQ10 are associated with cardiovascular disease, diabetes, cancer, brain disorders. Our coenzyme Q10 has really important things going on for energy production, or like for mitochondrial energy of our cells in our cardiac tissue, so in our heart. So it's really important to improve the energy production in the heart and how it works. But it can also improve how our pancreas functions and how our insulin responds to the presence of carbohydrates. It can decrease with age. So we do see that over time. So many patients that we do see are commonly on CoQ10. But one of the big things is that there are many prescription drugs, from cholesterol management medications to antidepressants and other things. I mean, there's the whole host of drugs that actually interfere with CoQ10-dependent enzymes. So taking these drugs for different symptoms actually lowers our ability to produce CoQ10 in our body, which is going to have all these protective components. So many times if someone is on a physician prescribed statin drug for cholesterol, you need to counter that with taking additional CoQ10 to get those levels back up. We looked at a lot of different information, from the common information that's pulled when we look at a laboratory assessment to more advanced testing that's available from Cenegenics physicians and others. And many times people ask, what can we do today? I didn't look at my labs, I didn't do this, but now I'm motivated. And as I mentioned before, I may sound like a broken record, but nutrition and exercise are going to do so much for you physically on the outside and also inside. Nutrition programs that are focused around low glycemic carbohydrates, so carbohydrates like fruit, vegetables, and other whole foods that are going to be supplying a very large amount of phytonutrients, a large amount of fiber. You're eating a lot of colors and antioxidants. All those foods that also aren't going to be doing a whole lot to increasing our blood sugar. When we eat all those foods, we get so many different benefits of micronutrients and phytonutrients, but we're also not going to have strong elevations in blood glucose levels or our blood sugar. So our insulin levels aren't going to rise up as well. So our pancreas can start to almost go through a recovery method. So it's going to be highly important for managing our risk factors over time and our inflammation. Focusing on consuming more fats that are higher in essential fatty acids. Fatty acids like omega-3s, as I mentioned, are going to be very important. Omega-3s can be consumed through different types of fish, nutraceutically through fish oil, whole eggs, not eaten completely freely, but having some whole eggs every now and then that are omega-3 yolks. Eating macadamia nuts, those are also high in omega-3s. And this is kind of shifting because the standard American diet is commonly more in omega-6s. An ideal ratio of omega-3 to omega-6 is a 1-to-1 ratio. So you're eating lots of good fats from these kind of seafood sources. However, the standard American diet is a 15-to-1 ratio of omega-6 to omega-1. So it's actually our common diets across the board that we consume in the US are pro-inflammatory. So while eating fish a few times a week seems abnormal for some, it can do a whole host of benefits for our cardiovascular health and improving our inflammation. It's not the only answer, but it's certainly something that can help. We also want to manage and avoid inflammatory foods. So this is actually discussed in another one of our presentations about different types of additional testing or food and allergy testing. Each individual responds to food a little bit differently. They can have a immunologic response to consuming something that they have a mild allergy to, or they can have something non-immunologic. So it's going to be more like your lactose intolerance. But regardless, if you're frequently consuming foods that yield a low-grade sensitivity, so if maybe you shouldn't be eating, shrimp, you don't have anaphylactic shock, but it's something that's coming up as a potential allergen for you. You might not experience allergies, but at the cellular level, we could actually have more chronic inflammation, and over time in the GI tract, that can lead to a leaky gut, and that would really increase our chronic inflammation, and that would really just speed up the process of the potential heart disease development that you may be experiencing. Cruciferous vegetables are also going to be important. So things like cauliflower, broccoli, cabbage, Brussels sprouts, those kind of pungent vegetables, they're actually very high in indole 3-carbinol. So that can help with estrogen management. So that can help aid in the hormone management side of things as well as providing fiber and all the other phytonutrients that you would get from other fruits and vegetables. Moderate consumption of proteins. We are all for consuming protein from a variety of sources. We just want the sourcing that it's coming from to be of the highest quality. So if you are eating red meat, we want it to be, grass-fed, free range. If it's even if it's from local hunters from a certain hunting season, if it's wild caught fish, even if it's a plant-based protein, if it's coming from a very raw source that's not been manipulated or manufactured significantly, those are also potential options. We want to focus on having a plate of food that is primarily fruits and vegetables, moderate amounts of proteins, and also fats coming from a variety of sources. On the exercise side of things, I'm strongly in favor of resistance training and high intensity interval training. In many cases, if someone in this scenario has these risk factors, it's going to be potentially of someone's best interest to focus in on dedicating the first amount of time to high intensity interval training. So high intensity interval training, we prescribe to all of our patients. They will perform a VO2 max test during their evaluation day, and we see where they go into their anaerobic levels. And those anaerobic levels are essentially high levels. And when you get up to those zones, you're not only improving your growth hormone output, you're not only just improving your testosterone concentration, but you also create what's called an oxygen debt. So our bodies are going to go deep into this oxygen debt, even in a 15-minute workout. And after exercise is completed, we're going to be kind of repaying that debt by what's going into EPOC, or excess post-exercise oxygen consumption. And in that time period of even 10 hours, 12 hours, 24 hours, depending on the size of the individual and how hard they exercise in that short window, they can be burning a higher amount of fat calories. So that's where our patients see so many different benefits, because they're doing this short windows of training, but they're doing it fairly aggressively. And aggressive is relative to the individual. Someone coming in who walks up the flight of stairs is tough for them. Their interval training is going to be mimicking walking up a flight of stairs. Someone who maybe runs, 5Ks every weekend, or they are a bodybuilder, they might be doing more sprint training on a certain type of cardiovascular equipment. But the intensity or the perceived exertion experienced by both is going to be the same, even though the actual training that they're doing is pretty different. There's additional nutraceuticals that can be used, as we talked about CoQ10. Vitamin K2 and vitamin D3, many times in combination with each other, are utilized a lot. Magnesium, many people have low magnesium levels. Omega-3s that I mentioned coming from marine fish oils, or also krill oil. Krill oil has a little bit of benefits because you have additional antioxidants that are there. For anyone who's vegan, there are some omega-3s that can be done from I believe, new seaweed supplements, but they're going to be more strongly DHA. Curcumin, a strong anti-inflammatory. Red yeast rice is used by some with elevated cholesterol levels. Resveratrol is another great one. Ashwagandha. Beetroot is going to help with vasodilation. That can assist with blood pressure. So there's a whole host of nutraceuticals. But it's tough because, without knowing certain things from lab work and from different testing, you just want to go out and incorporate everything, when really the best scenario is when you kind of speak with a physician, look at your labs, and look at the things you're missing, and then utilize the nutraceutical recommendations from there. Also doing the diagnostic assessments, as we mentioned, having excess body fat is a significant risk factor for developing heart disease, and more fat that's around the trunk or in the abdominal cavity. So that would be visceral fat. So looking at a DEXA scan, Cenegenics, we do DEXA scans on all of our patients during their elite health evaluations, and also for follow-up when they are in office. So with that, we're able to look at total body fat percentage, trunk fat percentage, so the fat from basically their shoulders to their hips. And then we also look at android or visceral fat, which is fat that's around the organs. VO2 max testing, as I mentioned, looking at the dynamic cardiovascular output that the heart is capable of. And the one all the way on the right is our carotid intermedial thickness test. And that is a ultrasound test that's done on the neck at the right and left carotid artery, where we first look to see if there's plaque built up within the vessel walls. And if we do not see anything in that area, we'll actually turn the wand to how she's holding it in the image. And then we look at a view of the vessel and measure the thickness of the intermedia, that middle layer of that vessel wall. So as with anything, we don't want to just set a plan that's going to be executed for the rest of your life. Plans change. The biggest thing to stay focused on is to be ready to pivot, adjust, and change plans. And your direction of your plan is going to change based on the individual outcomes. If we start with doing not lower intensity, but if we start with doing the high intensity interval training and it's that flight of stairs, and we see changes those first 4 weeks and are fantastic, and then we don't see as much progress in the next 4 weeks in the labs, then we know that is time for us to increase the intensity of that exercise. So instead of walking up that flight of stairs, that might turn into walking faster up the flight of stairs, or maybe holding something walking up the flight of stairs, or even doing some other type of activity completely different. Nutritionally, if someone is consuming primarily vegetables and they elect to not eat a whole lot of fruit and they're just doubling up on their vegetables, and their blood glucose levels improve, their insulin improves, and their hemoglobin A1C improves, but then now they're saying they're lower on energy, we're going to start to include more energy-dense carbohydrates. So you're going to keep eating those vegetables, but now we're going to maybe implement some more fruit, we're going to maybe implement some more sweet potatoes, or different more dense carbohydrates that can provide that energy and still provide them with a lot of phytonutrients. So the take-home message is that each individual window of time, we're implementing a strategy for each individual. That's where strategies vary, and that's why patient programs vary. It's not just one plan that's a static plan that's followed time over time. We need to focus on one given strategy, make those changes, adjust, and move on to the next goal. And many times when people start a program, they think that it's like an image on the left. It's just one direction. You're going to blow through every obstacle. You're going to, make it work. It's going to happen. There's no choice, and you're only going to move forward. And while that attitude is fantastic, we want to have highly motivated individuals to really implement all these strategies we're going to incorporate. In the real world, we experiencing things that are out of our control. So our plans, or how the patient's outcomes are over time, are much more like the image on the right, where we're still going in one solid direction, but there's certain things we need to weave around. If there's travel involved, if there's a work schedule, if there's issues with some food that they're consuming, there's a potential injury, maybe something happened at work. We need to find changes in this. We need to shift the strategies sometimes to continue to move on in the same direction we want to go. Otherwise, we're not going to be able to move forward. So we always want to adapt. We want to flow with what's going on with the patient in their life, but focus on that goal and then pursue new goals after we reach them. And lastly, this is a quote actually from the author of Sherlock Holmes, and it is a capital mistake to theorize before one has data. And we can implement all of these different strategies, but unfortunately, when we do so many things at once without knowing what's going on, we're essentially throwing something on the wall and see what sticks. And that's what many people do at home. Many people see January 1st happen. They read a certain book, they saw a certain movie, they read a certain celebrities doing something, and they can relate to certain things, and they become motivated and they just start doing X, Y, and Z, and hopefully something works. When really, take that same motivation and focus on looking at your information. Look at your heart function, so your VO2 max testing, your advanced laboratory results, your body composition, the thickness of your intimate media. Look at all of these risk factors, look at all of this data, and look at it on paper and say, okay, this is my number 1 priority, this is my number 2 priority, this is my number 3 priority. And then we map out a plan to help you get there. Because then not only are you're not wasting any energy, essentially focusing on including absolutely everything you can, you're dedicating all of your energy to really specific technical goals that are going to help you reach them. So again, I'm Rudy Inaba. If you have any questions, please feel free to reach out at 866-240-0035. We're happy to answer any of your questions related to Cenegenics, heart disease and stroke prevention programs, our elite health evaluations, our testing services, from DEXA scan to VO2 to carotid intermedial thickness tests. We have centers all across the country at 20 centers across the board, and many of our physicians are absolutely ready to speak with you. So if you have any questions whatsoever after today's webinar, please feel free to reach out. We're happy to get them answered for you. So I'm open to taking any questions. So I'd like to have my plaque checked. Can you give more details about the procedure? So a couple different things. So there's a few different forms to get plaque checked. If you have a significant history, and if you are very well diagnosed with heart disease, there are advanced tests that you can do with a cardiologist. However, if you are younger, you haven't been diagnosed with heart disease, if you exercise, you're doing a lot of things right, and you're just really unsure, the carotid intermedial thickness test can be highly beneficial, as we're able to really assess your risk of developing heart disease before it's actually been diagnosed. So essentially, to explain a little bit more, so we first look to see if there's plaque built up within the artery. So if we're looking down like a vessel wall, use this, excuse me. So if we're looking down your blood vessel here, so we're going to see if there's any plaque built up or plaque inside of that artery. And if we see that, we know that there's plaque and there's going to require some intervention. So we're actually going to take the imaging and the video from that test and provide it to you and your cardiology team to have the intervention. In many cases, we don't see plaque built up because we are more proactive and our patients are more prevention minded. We're actually going to take that ultrasound and turn the wand laterally. And now it's as if I cut this paper towel roll long ways. And long ways, we're going to measure the thickness of that inner wall. So that inner wall is going to be our intima media. And if that is within range, we know that our wall of our vessel is normal and that it's not inflamed. But if we have chronic inflammation, if we have elevated LDL, we have those advanced profiles that are elevated as well. This inner wall, or this cardboard layer on the inside, becomes thicker and thicker over time, leading to more atherosclerosis, so hardening of the arteries. And also it can rupture on the inside, and then it can start to build and accumulate more plaque. So for someone who is interested in getting started and improving their health, I would first suggest this during our elite health evaluation that we do on all of our patients for our elite health evaluation, to really see what those risk factors are. And then if we see something that's far more advanced, then we would pursue more advanced testing. So what can I do to increase my CoQ10 levels? So I would supplement with CoQ10. We used to say things that, and these are not clinical recommendations by any means, but if someone was on a certain milligram dosing of statins, we would do 100 milligrams of CoQ10. If someone was at a higher dose per day, we go to 200 milligrams of CoQ10. But really, you do need to supplement with it in most cases. Another great thing to do is to look at a full comprehensive profile of what other nutrients you may be missing out on. We do micronutrient testing as well. So we can see, we look at CoQ10 from the labs we just talked about from the advanced heart disease and stroke prevention. But there's additional ones we can look at when we look at micronutrients and look at how low our essential fatty acids are, what other nutrients are low, to see if we can really maximize our cellular health. I find it hard to stick to a plan, diet and exercise, due to travel for work or time constraints. So how does Cenegenics program adjust for my needs? And that's one of the biggest things we talk to our patients about, is that we could throw the most strength conditioning minded clinical program, the most comprehensive thing at you, and hand it to you in a pretty box to open and take home. But if it cannot be applied, then it's not worth anything. With Cenegenics, we need to first understand the relationship we have with our patient. If we have a patient that is, in a highly stressful environment, they have a very hard schedule, there's a lot of travel, we need to identify, each different stage of the patient's program, we identify which priority items are most important to improve. In many instances, it's insulin sensitivity, because many of our patients come in with insulin resistance. But for some, it could be these heart disease components. So we focus in on what the priorities are, and then put almost all of our attention into those first three priorities until we start to change them, until they are really no longer risk factors. And then we adjust. Now, to answer the question, is that if someone only has 30 minutes, maybe 4 times a week, 3 times a week, that gives us 30 minutes to dedicate some type of effort into changing those numbers. And when someone is traveling and eating and everything, we give the tools and the resources and the coaching, and we're available, really at all times to answer any questions on how to order certain foods, how to prepare for travel. Many people say, oh, bring your own food, prep your own meals whenever you're doing that. That's great. I mean, people do that. I mean, I'll do that when I have the time. But in many instances, it's a patient saying, I eat here, here, and here when I'm traveling. What are the best things for me? And we'll go to looking at the menu, we'll pick menu suggestions, and we'll give those to the patient to actually have. So when they are traveling, there's no questions. We kind of answered all those things for them. I have multiple health concerns. Would you recommend your heart disease, your heart and stroke prevention program, or your genetic testing? So you do get some genetic testing in the heart disease and stroke prevention. As I mentioned, you have you have 3 different genotypings that we'll do with the heart disease and stroke prevention. It's really up to you. I mean, in an ideal scenario, I know this is an obvious answer, you would do both. But the genetic testing is really interesting. It's going to give you a lot of information, and it's also going to continually update. So as we find new things in the medical community, and as there are new things related to the human genome, the labs, we actually will give you updates on what new risk factors are, what strengths are. But as for the heart disease and stroke prevention, I think if you have a family history of heart disease or stroke, if you are experiencing some of the initial risk factors that I mentioned that are commonly observed, if you need like a starting point, I would recommend the heart disease and stroke prevention right off the bat, because that sounds like it would be kind of like a #1 priority to go for, with maybe potentially down the line doing the genetic testing. If you're an individual that already has all these levels done, you've done all these biomarkers, you work with your physician on this, and you are just interested in knowing yourself as much as possible, I think the genetic testing can be very interesting. It's a one-time thing, and you can do that long-term, and you can have those results long-term. I have never had a good relationship with food and constantly eat things I know I shouldn't. If I change my diet drastically, does this reduce my risk of heart attack and stroke? Yeah, it very well can. Really, if you think about it, so our heart supplies oxygenated blood to all of our tissues, and our muscle, our bone, our fat. So muscle and bone are metabolically active tissue. If you were to have like an investment portfolio, your muscle and bone would be, a very valuable thing because it's metabolically active. It gives you a lot of benefits. Having a certain amount of fat is absolutely important. We need a certain amount of fat to survive for hormones and a number of things. But that excess fat, when you have excess fat, that's just a burden on our heart. Because if we have, over 5, 10, 20% excess body fat, our heart still needs to work to supply oxygenated blood to that tissue. So if you lose some of that fat from eating better and exercising, not only when you're eating better, you're supplying yourself with better nutrients. So as we said, essential fatty acid consumption can improve our risk factors. So if you're eating better and having essential fatty acids, that's great. If you're having phytonutrients that are anti-inflammatory from fruits and vegetables, that's also great for your diet and long-term for heart disease and stroke prevention. If you're exercising to a more aggressive level, really not even at aggressive level, if you're exercising at all with a positive intention, that can yield a great thing. And then as the outcome of that happens, as you're losing the body fat and building tissue, that's all going to create this synergistic lifestyle that can really turn around your risk factors for developing heart disease and having a stroke. So, you need to take it one meal at a time. Don't get down on yourself if you have a history of struggling. Don't beat yourself up over falling off for 1 or 2 meals. Just think of every time you eat or every time you have the opportunity to exercise as trying to get a small win. And over the 1 month or the 2 months or the 6 months or the year, the more wins you have under your belt, the better off you're going to be. For some people, it's a slow start, and it happens, but it's better to have a slow start than to not start at all. And for some, sometimes they need to have a cardiovascular event in order to be the kick in the pants to really push themselves and really stay committed to the lifestyle changes. And with that, I believe I have all the questions. So again, if you have any questions after today's webinar, please feel free to contact us. The number is 866-240-0035. You can speak with one of our Cenegenics physicians and also prepare for a Cenegenics Elite Health Evaluation at any of our 20 centers across the country. Again, I'm Rudy Inaba, and thank you everyone for joining.